Good evening, everyone. So it gives immense pleasure to start the Viewpoint by News, North, East, West, South by Oxy, Foxy, TNFOG. We have a webinar on Recurrent SUI. Now I welcome all the faculties, Professor Shrikala Madam, who requires no introduction, but gives me immense pleasure to introduce on behalf of our president. We would like to welcome faculty. Shrikala Madam, can you just share Shrikala Madam? Meera Raghavan Madam. Shrikala Prasad Madam, she is the Vice President, South Zone, SOFC. Authored chapters in textbook of Urogynecology Simplified. JP Brothers contributed chapters in Foxy Focus. Authored chapter in Medico Legal in Obstetrics and Gynecology, JP Brothers. And
Romina.
And over to you, Madam, to present the case. And now like to request the chairperson, Dr. Naini Tandon, who is the President, Lucknow Menopause Society, and the experts, Dr. Neeta Thakre, President, AOGS 2025-26, and Professor Subhash Chandra Biswas, who is the Principal, PKG Medical College, Kolkata, to give their expert comments on the case presentation by Shrikala Madam, Recurrent SUI. Moderator will be Dr. Meera V.V. Raghavan.
Okay. So shall I share the...
Yes, Madam.
Yes, Madam.
Yes, shall I share my presentation?
If there are any questions from the delegates as well as any faculty and expert, we can post it on the chat box and we will moderate those questions to Shrikala ma'am at the end of the presentation. Thank you.
Good evening.
Does not require any introduction. Meera Madam is Medal Meera, who is won more than 30 medals and convener of the news. And we would like her to moderate the session. Over to you, Meera Madam. Shrikala Madam, to take over
Yes,
the
ma'am. Yes,
presentation.
Thank you. Thank you for this wonderful opportunity to talk on my favorite topic, SUI, and more specifically, recurrent SUI. So when a patient comes back to us with complaints, either comes back to us or comes to us after having operated elsewhere, we need to reassure them, first of all, that their problems will be heard completely. They will be evaluated methodically, and whatever possible corrective measures will be undertaken. Because they will be, one, angry that they have not become all right, two, they will be very worried. So we really need to take care. So, how do we evaluate? We need to know what is worrying them now. Do they have a persistent urinary leakage? And is it like leak on cough, laugh, sneezing, any exertion? Or is it now only urgency? Or is it a continuous urinary leakage like seen in a fistula or mesh erosion? And is it the same as a pre-procedure or is it different? Then we need to know what is the severity of the leak and how bothersome it is. If the leak is very small, then it's not a big issue. But if it's a bothersome leak, then we really need to take care. And also, do they experience any voiding difficulties like difficulty in passing urine, need to strain, incomplete emptying, etc. And see, this is a recurrent case. So we need to go to their records. What was their original problem? What was a clinical assessment and evaluation performed? They need to be reviewed. Did the patient have any preoperative voiding dysfunction earlier? Was a urodynamic evaluation done? Because many places urodynamic evaluation is not known. And in any of the evaluations, were there any red flags noted? Was there anything to be worried? And the type of surgery done, the operative technique, the materials used during the surgery can be obtained from the discharge summary. Similarly, we can also find out if there is any mention of intraoperative complications. Other pertinent history, like obesity, we know. So, is there been a marked weight gain? They're doing any strenuous activities post-operatively, smoking, And again, an assessment, multiparity, postmenopausal status, presence of coexistent pelvic organ prolapse, neurological disorders, looking for multiple sclerosis, spinal cord injury. In our country, diabetes, we are the diabetic capital of the world. Look for chronic cough or constipation. Physical examination. So, in addition to the routine examination, we look for, I told you, obesity, chronic cough, abdomen. You need to palpate for bladder distension, because two things in bladder distension, we know either there is an obstruction to the outflow, or there is inability to empty the bladder. Could be a hypotonic or an atonic bladder or a neurogenic bladder. Or is there any mass or any hernia? Patient is examined in the dorsal lithotomy. You look for mesh erosion or exposure and assess for vaginal atrophy or discharge. And so the stress. So now she's come with stress incontinence. So again, we need to do a cough stress test. And many a times we've been repeatedly telling this. You do with this with a reasonably full bladder to assess leakage. At the same time, we need to look at the urethra. Here, if you are able to see a leakage with a fixed immobile urethra, it is indicative of an intrinsic sphincter deficiency. We all need to know that ISD is you need a robust surgery for ISD, like a pubovaginal or a retropubic taping. And as the patient coughs, you can assess whether there is hypermobility of the urethra. And another important test we always tell, when you examine for SUI, we do a reverse gynae drill. That is, in all patients of gynecological examination, we examine the patient with a full bladder. But if the patient is coming for SUI, you examine the patient in a comfortably full bladder. And one more thing, we have to examine the patient in an empty bladder also. If the patient leaks urine, even in a near empty bladder, again, that is a pointer of intrinsic sphincter deficiency. Again, here I'm going to give a similar scenario. A 56-year-old lady evaluated for recurrent SUI. She has had a transobturator taping done elsewhere about 5 months back, and she has come with again recurrent SUI. She says it has not become all right at all. But during the history, she says that even on a trivial stress, like she tries to clear her throat, she has got marked leak. So such is the inefficiency of the sphincter, so much so that we know it is an intrinsic sphincter deficiency. And clinical examination, you will show, as I was telling you, a fixed immobile urethra with leaks even on a near empty bladder. All these things are pointers towards an intrinsic sphincter deficiency. So intrinsic sphincter deficiency needs a robust surgery like a pubovaginal sling or a retropubic taping. And while we are examining her, you palpate for pain, trigger points, or induration indicative of infection, fibrosis, scarring, or hematoma. Look for any evidence of fistula or infection. Again, pelvic organ prolapse examination, that is known to all of you. Also, don't miss to evaluate for pelvic and perineal sensation, reflexes, and motor strength to rule out neurological contributors. Ultrasound is like an extension of the clinical examination. So, now again here we are seeing a recurrent SUI. So, we also need to assess if there is any retained material, hematoma, or abscess. Apart from the complete examination, a very crucial step is in assessing the post-void residue. A significantly raised post-void residue serves as a red flag and warrants further evaluation. I was talking to you when you say that's a distended bladder. Again, it is a red flag. So here, either distended bladder or an elevated PVR, we should know the two important causes are: one, there is obstruction; two, there can be atonic or hypotonic bladder. In that, urodynamic evaluation is really required. We'll come to that a little later. Ultrasound can also be done as a transperineal or translabial ultrasound. Why this is important? Many a times we see that a sling has been put, But if you assess and she comes with recurrence, but when you try and do real-time imaging, even with Valsalva, you see that the sling is not properly placed. It is possibly migrated. So an experienced radiologist will be able to assess the position and dynamics of the sling, and also you can recognize local complications like stone formation or a vaginal exposure. The radiologist, he or she, will be able to determine whether the sling is properly placed or if there is excessive tension, migration, or deformation. So that sling will be not of any use. We have to give her next treatment. Then urodynamic evaluation. See, in simple, straightforward cases, many times you can skip a urodynamic examination. But in case a patient comes back with a failure, or you have a suspicion of neurogenic bladder or any other symptoms, it is better to do a urodynamics. In the very important point which I was talking earlier is where patients have an increased post-void residue either because of obstruction or a hypotonic bladder. Both of them, the combination will be, they will have a low flow rate and a high post-void residue. So how are you going to distinguish this? If the patient will have obstruction, again, because of the obstruction, there will be low flow. But because of the obstruction, they're trying to strain, so they will have a raised detrusor pressure at maximum flow. That is, P-det at Qmax will be high. But the patient with hypotonic bladder will have a low detrusor pressure at maximum flow. That is, P-det at Qmax will be low. So what we need to know is, if the patient has got a high PDET at Qmax, they are obstructed, and
Can Chitrakala
can,
mute everyone? Because madam's voice, we are not able
no,
to listen.
yeah,
Chitrakala, please
I'm
mute
able to
everyone.
hear other people talk. That is right. So
Yes,
if
yes,
the
madam.
patient is having obstruction, they will need a sling revision or a erythrolysis. Similarly, in cases of a neurogenic bladder, those with low PDET at Qmax, so there will be a lot of residual urine, and patient will even leak when they cough. These patients will not benefit from surgery, and what they need will be actually a clean intermittent catheterization, and they need more evaluation, and possibly there is a role for sacral neuromodulation. I was talking about IST. So, how do we differentiate? Abdominal leak point pressure is a measure of sphincteric strength. Abdominal leak point pressure is a total P abdomen required to cause urinary leakage on coughing. So, if you talk of intrinsic sphincter deficiency, the sphincter will be very weak. So, the abdominal leak point pressure will be less than 60. Even with that pressure, they will leak. If it is between 60 and 90, it is equivocal. And if it is more than 90, then we know that there is little or no IST. The point we need to remember is, patients with severe IST, that is the ALPP is less than 60. I was talking that they leak with trivial trauma, they leak in an empty bladder. All those patients will require robust procedures like a pubovaginal sling or a retropubic taping to achieve continence. So this is a picture where here you can see that, the leak very less, even with 60 it leak. So that is intrinsic sphincter deficiency. This is an intermediate zone, and if it goes more than 90 and then only they leak, then we know that there is no intrinsic sphincter deficiency. Then patient has had surgery, and then again they come with leak. All leaks may not be because of another stress urinary incontinence. It could be that they have this leak because of an urgency. What urgency may not be there earlier, the patient could have developed urgency, what we call a de novo urgency. So, if the patient has detrusor overactivity and leak, they will benefit from anticholinergics like solifenacin and beta 2 adrenergic agonists like mirabegron. So again, I will talk to you a small history. So 46-year-old lady, mid-urethral sling, done for SUI. Patient comes with real bothersome complaints, real bothersome, even after surgery. And she complains of history of leakage of large quantities of urine after coughing. Normally, in SUI, when the patient coughs, at the time of coughing, synchronous with coughing, they will leak small quantities of urine. Whereas in an overactive bladder, the moment the patient has a desire to pass urine, they will leak large quantities. So here the clue is the patient leaks large quantities of urine after coughing. I have not written synchronous with coughing, it is after coughing. So we'll see what is it. This is a condition called cough associated detrusor overactivity. This cough associated detrusor overactivity is a condition where the detrusor overactivity is triggered by cough. I'll show you the graph later. The coughing causes a rise in P abdomen as well as in P vesicle. And seconds later, the patient gets an involuntary contraction as seen by the rise in detrusor pressure, which continues long after the P abdomen returns to baseline. See, we'll show this next picture. See, there is a cough. Can you see? P abdomen raises, P vesicle raises. But at the same time, there is no rise in detrusor pressure. But after the pressure comes down, the patient develops a contraction. This is an involuntary contraction. There is no cough. The P abdomen is flat, but they develop a involuntary contraction. So this is what we call cough associated detrusor overactivity. So the cough will stimulate the overactivity. So the treatment is not surgery for cough. You have to treat it with an overactive drug. So if you don't do urodynamics, you may only think patient coughs and leaks, and she's got a lot of leaks, so better take up for surgery. So without urodynamics, this may look like SUI, but it is actually an involuntary contraction and should be treated with anticholinergics like solifenacin, beta-2-agonism. So here, so even though meduurethral sling has been done, this patient was leaking large quantities of urine after coughing. So you have to think in SUI, the moment they cough, they leak synchronous. But if there's a little gap and they leak large quantities, think of CADO, think of giving drugs for that. Okay. Now, again, so I hope we have the experts with us. So we can have any of them join.
Yes,
Yes,
could you
madam.
listen to me,
Because I'm not
Srikala?
able to see. Yes, sir.
Subhash sir has joined.
Sir, namaste. Namaste, sir. Subhash,
Namaste.
sir.
Subhash sir has
Yeah.
Namaste.
joined. Neeta Thakre
Okay,
ma'am has
Asika,
namaste,
joined.
sir.
namaste, namaste.
Namaste. Namaste,
Welcome,
Yeah,
sir.
Subhash, sir.
yeah, yeah.
Namaste.
Yeah.
Okay, I'm very, very happy, sir. Thank you. Thanks for
Uh,
joining us. So,
okay.
with
No,
what
it's
do you
very,
do, sir?
no, you have rightly
Chitrakalam, please
mentioned
unmute Neeta
the
Thakre, madam.
I'm
Nita
not
has,
able to see Neeta, madam.
Nita has joined.
Yes, sir.
Ah,
Yes,
We
madam,
can
she has
see, we
joined.
can see.
Chitrakala, please unmute Neeta Thakre, madam. Welcome, Neeta Thakre, madam, and
I
Subhash.
can see madam's name, Neeta Thakre. But the camera is not on.
Yes, the talk so far
Yeah.
Srikala has
Now,
delivered is very nice to know because she has scanned the topic so nicely that usually we think that SUI doesn't need any sort of aerodynamic study. But she has cited very, very good examples, few of the good examples where we cannot go ahead or we cannot achieve success without having aerodynamic study. So she nicely pointed out the cases which are to be screened first to rule out. Or if it has come as recurrent SUI, then here lies the importance. To start with, she initially also told the importance of history taking, including the medication history, then the comorbidities history, that need to be excluded first to take the patient for surgery. And once the surgery has to be done, usually we don't go for urodynamic, we go for straightway the gold standard. Okay, if it is mid urethral, we go for mid urethral. But later on, if she is not, she has not been improved so much, then in that case, not only she is frustrated, but also the urologist or the urogynecologist is also at the risk of your litigation because she may be aggrieved. So possibility of litigation is there. That's the reason, if we think of after taking proper history, then thorough examination, this is a complicated case, or this may not be very simple SUI. In that case, better to go for urodynamic to start with. Then and then only, as Srikala has nicely pointed out, all these things can be evaluated prior to surgery, whether it is intrinsic sphincter deficiency or it is urethral hypermobility. What's it is a case like CADO, or it is a case like abnormalities of your post-birth residual urine. So this is very important. She has given much importance of those things which are usually overlooked by the urogynecologist. Yes, any comment from
I,
Nita?
I wanted to put a point across. If
Yeah,
there is a case of intrinsic sphincter deficiency, and if she has been offered TOT, then there are chances that she might not have uh, give
yeah,
res-
yeah,
got a good results.
yeah.
The kind of choice of the surgery that was offered to her. So it is very, very important to find out whether the factor like intrinsic sphincter deficiency is major factor, or urethral hypermobility
Hypermobility.
is a
Yeah.
factor. So in these cases, maybe you may find that the SUI is recurrent. So this is pure recurrence and not because of you missed the CADO.
Yeah.
Yeah.
So
Very true, madam. That is why I was going on reinforcing that factor. If there is an intrinsic sphincter deficiency, robust surgeries like a retropubic taping or a pubovaginal. Other surgeries do not really help if it is an ISD. If it
Yeah.
is a urethral hypermobility, yes, TOT helps,
Yeah.
really helps.
I joined little late because of some patient, so I have missed that part. And you are
Yes, ma'am.
such a good teacher that I feel that I should not have missed that.
yeah. No. Sikola has nicely pointed out all those
Yeah.
points to
Yeah.
start with.
Meera, you should provide me with the recording.
Definitely, ma'am.
Yeah.
Okay.
So
Ma'am
that
is actually now pretending to be a student, which is
yeah,
also teaching at the same time.
not she is teacher's teacher, yeah.
Yeah,
Yeah.
truly. But she's pretending now. So she's
Uh,
quite confident. So that's good.
Absolutely.
and she's such a good teacher, I must say
Yeah,
that.
yeah, very,
I,
very
I,
practical.
yeah,
Very
very
practical.
practical and to the point, and the way she describes, no one can not understand.
Absolutely.
You know?
The important point, Sikola always scans the case as a case-based scenario.
Yes,
So
yes.
what is the case, the diagnosis, then analyzing the pathophysiology. She
Yes.
always opts for mode of treatment.
Yeah.
For years together, I have seen her. Really a nice teacher.
Very true. Very true. I second that.
So I just wanted to complete one more slide.
Sure,
Uh,
madam. Please go ahead.
no, just this. Yes, okay. So, now we were discussing that. So, what would you do? Uh, so, place whether we can place a second synthetic midurethral sling, preferably if it was earlier transobturator, we can go in for a retropubic tube route, or a panacea for everything is an autologous. You can do this for urethral hypermobility. You can do it for intrinsic sphincter deficiency. Autologous pubovaginal sling is a wonderful surgery. You can do this even while you are doing some surgery on the urethra, like you are going to do a stricture disease, you are going to do a urethrovaginal fistula, or any urethral injury, any surgery on that synthetic mesh is contraindicated, so you can use an autologous. So that is a real wonderful surgery. The other surgeries, like even Bush, is now coming up. Earlier, it was done in a very large number, and then it came down. Again, we see more laparoscopic people doing thing. And salvage is artificial urinary sphincter, though we do not do so many cases. I think it is very done in a less number. What about Madam and Sir? Have you been doing any artificial urinary sphincter?
No, no.
No, actually, I have not done artificial urinary sphincter insertion, but obviously the failure cases after TOT, I have used the retropubic tape, and really it works if the diagnosis is correct.
Is correct.
In one case, actually, it didn't work because the diagnosis was little bit combined type of urinary incontinence rather than thinking of it is the intrinsic sphincter deficiency, but it was combined urinary incontinence. So in that case, we should always exclude also, and we should treat urge incontinence first. Autologous pubovaginal sling is good option to start with, or the second in recurrent case. In one case, I found voiding difficulty after autologous pubovaginal sling. So after doing catheterization, even she didn't improve. Then fifth post-op day, I took her to OT and I made a small nick suburethrally. I saw that autologous sling is come more your distal portion of the urethra, distal portion of the urethra. So in that case, I pushed it back, and it was good width. So I make a nick on the anterior aspect, and the rest of the part I was able to push down mid urethra, and she improved very nicely. She is very happy. Even she comes for follow-up. Yeah. So that may also happen. When we go for autologous pubovaginal sling, be careful whether it is going to be on distal insertion.
Sir, I would, I am a real, admirer of that pubovaginal sling. The initial first year when I was doing, now I've been doing it for more than 20 years. The initial 1 or 2 years, I did have avoiding dysfunction. So much so that even today, I also counsel about the need for catheter, etc. But I saw one Austrian study where they said rule of 40 mm. So that is when you bring the rectus sheath above and you tie it, you keep 40 mm between the rectus sheath and your knot. So that rule, that study changed my practice. From that day till today, I have not had a voiding dysfunction after pubovaginal sling.
Madam,
That's
can you
good.
describe it once again?
Yes, madam. There is a study which says this 100% I agree, voiding dysfunction is an important part of pubovaginal sling. But how do we overcome it? When you bring that pubovaginal sling above, and we are going to put a knot in between the two ends of the proline. When you tie, don't flush tie it over the rectus sheath. You keep 40 mm. Before we were keeping that your cystoscope sheath, etc. 40 mm, 4 centimeter between the rectus sheath and your knot. The meaning is it is not going to be tight. There will be no obstructive voiding. So that one single change in the philosophy, in the practice of surgery, I have not had obstructive voiding at all. That is point number one. Point number two, in when we are doing a pubovaginal sling, God forbid we get a obstruction, we don't need to go from below. We don't need to go from below and cut the sling at all. Above, make a small nick on our Fenton steel. Go deep. Your thread is lying there. Just cut the thread. But we would have brought it along. No, that will remain. Only the tying we are cutting. So that can be done under local anesthesia. There is no need to cut the sling. So these two things are really helpful, and we are able to. You try this, sir. I'm sure.
One
Okay,
question. One question.
Yes, madam.
Can we not tie and just leave like a sling which we leave?
No, madam. I have not tried that. I told you I have tried this after that study and I have had no problem at all. So I just tie it and then cut. So maybe what you say, if you don't tie it, may be better, but you tie it at 40 mm, it is beautiful.
No,
Maybe
Rita,
sometime later
madam,
somebody may say we have not tied, then it is fine. That is don't know. As of now, the studies are favoring that, and
okay,
after I
okay.
more than 20 years, I have no problem. It is very very useful.
I
That
know,
is,
Dr.
Shrikala,
Sri.
that
Yes, ma'am. Yes,
Shrikala,
ma'am. Please.
the knot,
Yes, madam.
the knot you said 4 centimeter above
Yes, ma'am.
the margin of
Rectus
the
sheath.
rectus sheath. Oh,
It will close the rectus sheath, madam, and then
okay,
tie the knot above. So
okay,
between the rectus sheath and the knot, you keep 40 mm.
okay, okay.
So again,
Ma'am,
my question to Dr. Neeta and to sir, supposing you have a previous TOT or a TVT, whether you want to remove the previous tape or you want to excise or you want to place a second tape over the existing tape, and what is your preference in if you're just going to do a midurethral sling and it is normal, it is not ISD, what is your preference, retropubic taping over transobturator?
yes, I can say my preference.
Yes, sir.
Actually, if there is no complications arising out of the tape, no
Yes,
point
sir.
of taking it or pulling it off. So
Yes, sir.
in that case, if I want to put on, I will put on the previous tape. Above on the previous tape, I can put another, or I can simply change the type of tape, that is not trans-obturator, putting it at trans erythropubic, or we can go for other method of your treatment. So no point of taking it. But if there is any complications, like it is too much surface, there is tape erosion, or there is some sort of infection, in that case only I think of removing the tape.
So,
Neeta, madam?
yeah, so I have come across 3 cases, and in those cases, patients did have tight uh, TOT. The sling itself was quite tight. It was like stretched to its maximum, kind of. And when I opened the vagina, I did not went all over up to the,
Point of entry.
Laterally.
lateral.
Laterally,
But
yeah.
mid segment, whatever tape I could get by simple palpation, it is not, because it was put quite a time back, means quite some time had lapsed between the first surgery and when I was doing the second one. So it was almost merged with the tissue kind of situation, and there was lot of kind of
Fibrosis,
tissue.
fibrosis, yeah,
The sling was not seen actually like a sling.
yeah.
It was taken up by the body. But then whatever little pieces I could get out, I could took out and then proceeded for the retropubic. So in that case, the
You prefer to remove it.
remove. Yes, yes.
Okay.
I
But even though so the moral we could take is, even if you tighten and put a midurethral, it may not always serve if there is an intrinsic sphincter. If maybe you may need to do a retropubic. So you have to orient yourself to the case and do accordingly. That is
Yes,
what you are
absolutely,
trying to tell now, madam.
Yes.
absolutely.
And retropubic is always a good, surgery to offer whenever there is a definite case of urinary stress incontinence and recurrence.
Okay.
Yes,
So
yes, yes.
I will I just okay. So can you please I that was this, and then okay. So placement of a second synthetic midurethral string, preferably a retropubic route, especially after it's a recurrence. Mild to moderate leakage benefit from this. Placement of an autologous pubovaginal sling with more patients who have got more leakage and more than one prior failed MUS and recurrent isolated SUI also benefit from this. Other than that, we were talking of Birch and okay,
Salute.
then
Yeah.
okay. Okay. So anything else, madam, you would like to offer? So what I wanted always to tell is this, throughout the medical practice, we say history taking and examination and then investigation. Like that, in this incontinence, very simple. If they leak, cough, laugh, it is a stress. If they leak with uncontrolled urgency, it is urgency, or they have mixed. And even the SCADO, they will clearly say they cough and a little gap and then they leak. And for ISD, madam, many a times in our country, we may not be having a urodynamic study in all places. So, at least for the patients who say, even after I go to bathroom and come and I get a cough, I leak. That is leak in a near empty bladder.
Bladder.
Think
Yes.
of an ISD.
IST.
Think
Yes.
of ISD if the patient says, I have a marked leak with a trivial stress.
Moment.
That's
Yeah. Yeah.
I just do this and I leak terribly, then it is an ISD. And some even say that they leak on vehicular jerks, etc. All these things will point towards an ISD. Actually, in the question, they were asking clinical examination. If there is a leak on a fixed immobile urethra,
Yes.
when the cough, it moves nicely, it's a urethral hypermobility. There is no movement at all, but it leaks. You have to think of an ISD. These are all clinical pointers to say that it is ISD. And once you think of ISD, do only real dogmatic surgeries. That is what I want to say. So good history taking, meticulous examination, necessary investigations, and a good surgery will prevent or minimize the number of cases who come with complications or the need for a recurrent procedure.
Yeah, madam.
Anything?
Madam,
Yes,
have we discussed the mixed incontinence, and if someone has not attended the
that's
third part?
our topic. Meera gave me recurrent SUI. So that is why I added one slide saying if the patient has, it could be either a de novo. Earlier they had only leak on coughing. Now they could be having leak, but this leak could be with urgency. Then it is a de novo urgent continence. The other factor which we need to know is patients can come with mixed urinary incontinence. In fact, many people come with that.
Yes.
There, what
And
should
you
we
have
do?
not put her on
Yes.
anticholinergics.
Yes. Here, especially what we need to know, the key word is deal the predominant symptom.
Yes.
If it is a mixed urinary incontinence, it is a stress predominant mixed urinary incontinence, you can take up for surgery and cover with anticholinergics. But if it is an urgency predominant, just put the battery number. If it's an urgency predominant SUI, urinary incontinence, then you must hesitate to put a sling.
Sling.
Cover her nicely with anticholinergics, and then if they don't become all right, you can
Put them on.
put them on. That is what. I was just wondering if my battery is just 1 second.
No.
Going down.
Ah,
Going down.
Illiyamma?
Yes.
Adullalla?
Yeah, Dr. Sikolar,
Yes, sir.
if some patients have come
Ah.
recurrent due to previous surgical failure,
Ah.
so they are very adamant not to undergo.
Just 1 second. 1 second.
Okay.
I will. My phone may shut down. I will talk it in the. Yes, sir. You tell me.
Yeah, she is very reluctant to undergo second time surgery. In
Yes,
that
sir.
case, what is your opinion if we just suggest for your minimal invasive mode of therapy? One patient was very reluctant, and I sent it to some urologist who has got all the facilities like biofeedback, then EAC laser or carbon dioxide laser. In that case, what is your opinion?
Sir, I do see a lot of doctors using that and saying that there is a good relief.
Recording in progress.
So just 1 second.
Yeah.
Because I think yes, sir.
Yeah.
Now am I audible?
Yeah,
Madam,
yeah, absolutely.
two devices are working.
Yeah.
It is bringing in echo because your two devices are there. I think both madam's phone got discharged, I suppose.
Now is it being hearing, madam?
Yeah, now
Yeah,
it's fine.
absolutely.
Yeah.
But,
So
but
the
You're not
other thing,
seeing now.
the laser and all those things are definitely coming up. Only thing is we still do not have real evidence. Evidences are coming, so we can tell, and including platelet-rich plasma, laser, stem cells. So many things are there. But the bottom line is, they have to take it with a pinch of salt. We cannot say that it is fully proven. But see, if the patient doesn't want to undergo a surgery, she understands the limitation of the minimally invasive procedures, there is no harm. We are not cheating her.
Okay.
We say
Okay.
that this
Okay.
can help. So it is up to her to try.
Thank you.
Many patients are saying they are getting relief. But if you send a patient who has got a marked leak, they don't improve with this
This
lasers and
minimal
other.
invasive procedure.
Yes.
Yeah,
So you have to
absolutely.
choose. As you
Yeah.
say, a patient who is reluctant for surgery opts for a minimally invasive. We have to counsel them the pros and cons and the current, what is the status of that. And then
Yes.
he's fine to go.
Okay. Thank you. Thank you,
Yes,
Dr.
sir.
Simpala.
Thank you, sir. Thank you.
Very nice discussion, actually.
Thank you, sir. Thank you. Any other thing we would like to add, sir? Subhash sir and Neeta madam?
Any other questions,
Yes.
anybody?
Dr. Naini Tandon ma'am has joined, and
Hello, Dr. Neeta.
madam is asking
Namaste,
for
Sabku. Dr. Meera, it was a wonderful discussion. And I'm so sorry for joining late. There was an emergency.
No problem, ma'am.
It was really wonderful. Thank you, Dr.
Yes.
Shrikanta.
yes.
This is one of
Doctor-
our kind. It's a
Yeah.
brainchild of our Sampat Kumari ma'am for regards the Oxy related urogyne activities. So basically, we are taking this viewpoint from experts from all over India. So all the experts will join from each zone, north, east, west, and south. That's why it's termed as viewpoint by news. So northeast, west, and south, and we have all the 4 stalwarts here from each zone who have enlightened all of us on a very common problem, which both the patients and the doctors are really scared of. There are many gynecologists, the moment they hear a patient saying incontinence, they'll say, that is how it will be, or you have to go to somebody else. So it is a very good enlightening webinar to start off with this whole series. We will be doing this on a regular basis.
And I'll now religiously follow it. It was really wonderful. Thank you
Thank
for
you.
making
Good.
it fun.
Yes,
Thank you
Dr.
so
Good
Meera,
idea.
Dr. Sampath,
And
thank you so
thank you,
much.
Shrikala ma'am, for playing the student and the prof. As
Yeah,
ever,
thank you,
so
Dr.
much
Meera.
elegance.
Thank you.
And thank you, Dr. Neeta Thakre ma'am and
My
Subhash sir
pleasure.
for chipping in. Thank you so much.
you.
And
Thank
thank
you.
you, Dr. Naini ma'am.
Thank you so much. Thank you.
Congratulations, Dr. Sampath.
Yeah,
Really, very nice. Good
Ma'am
idea.
has also joined.
yeah.
Excellent.
It's a
Ma'am was
good
supposed
idea,
to-
and it
Yeah.
is such a good feeling to see all of them on one screen.
Very
Yeah.
true.
Yeah,
Very
that's
true.
good. That's good.
Ma'am is actually
Yeah.
traveling, so she might log in a bit later also. Never know.
Yeah.
Yeah, but if we are done,
Thank you. Thank you. Thank you.
thank you.
Thank you.
Yeah.
Thank
Okay. See you then.
Thank you
you.
so much.
thank you.
Good night.
Thank
Thank
you.
you.
Thank you.
Naini
Good
Meet
night.
you all
Good night.
again next month
Yes, sure.
with the
In the
viewpoint.
next meeting. Thank you.
Thank you.